I want to spend about 10 minutes and just kind of put everybody on the same page here. Uh, Obviously, a lot has changed in the last year. I hope that you find this useful as you not only take care of yourselves, but take care of your patients as well. So fundamentally, we're at a point now where things are different. And I think it's very important to understand some basic numbers. We are in a position now where there is really no further lockdowns. People are in a position where they are essentially back. They're back at work. You're having about 84% of people back in the actual workforce back at work. That means no virtual work. 72% of students are in person. That's public school data. This is nationwide. 73% of TSA numbers are at pre-COVID levels, meaning on a day-by-day basis, about 3/4 of pre-COVID air traffic is occurring on a daily basis. 60% of US adults right now have 2 complete vaccine doses in arms, but only 34% of 12 to 18-year-olds are fully vaccinated. So given that's where we are now, with no lockdowns, masking is highly variable. We don't know what's going on with hand washing. This is where our numbers are. Given that's the case, compared to our January surge in California and nationally, total daily cases are down 35%, or 35% less than that time. And more importantly, deaths or fatal events from COVID are 68% less than where they were. So clearly something has changed. And again, there's arguments that we're not testing enough people, and there's probably more cases, and that certainly is true. And there's also arguments that a lot of the case positives right now are people who are already vaccinated, which we'll get into. But the overall point here is that we're at a very different place. The country is far more open. We're in a far more higher risk of transmission, and yet we're in a position where basically we're seeing less total disease burden. And that's purely because of antibody-based immunity, largely due to vaccination, and some degree due to post-infection states. I'm going to just briefly mention this again because I brought it up at the last time we spoke. Remember that all the vaccines that we have right now are purely targeting one thing, and that is your spike protein. COVID spike protein is the only manufactured target right now as far as antigens. There is nothing targeting nucleocapsids and nothing targeting other protein derivatives, which are also important aspects of the disease state. Now, in the future, that may change, but that's something to note. Another very important thing is the concept of adjuvant. We talked about this briefly, but remember that classical adjuvants that have been used in the past for decades are aluminum-based adjuvants. In the last 10 years, those have now switched to fatty acid or fat-based adjuvants, which are also equally strong. But these vaccines that we have, Moderna, Pfizer, actually don't have a clear, well-developed adjuvant. And so what that means is the vaccine is going to create a response, but it's not as stimulatory a response as we like to see as in other vaccines, such as, for example, Shingrix, which is a single-dose vaccine for adults, which has a very unique type of adjuvant that allows for one shot and you're done in people who are in their 50s. So the point is, expect to see some changes there in the vaccine and particularly in the booster side of things, and hopefully that will create less side effects with more long-term immunity as we move forward. One last little point on this as well is that everything that is happening right now, whether it's vaccine-based or infection-based, produces 2 types of immunity, one that is short-term, one that is more medium-term, not long-term, but more medium-term. And so the vaccine effect that we are trying to study right now is largely in the B-cell aspect, but we are also trying to study the T-cell immunity, which I'll talk about briefly. But remember, as time goes on, the immune system, as it sees more and more different types of virus particles within the coronavirus, especially COVID state, you will continue to see a build on number 2, which is cellular immunity that is not necessarily based on pure infection, but pure interaction with this virus in the native environment. I do want to explain what this is technically doing. So the GISAID, which I won't go into the details of that, is your largest single database on mutant and variant strains of many different viruses, but particularly focused on COVID. It's based out of Germany. the whole point of this is you see the trajectory here, whether you're looking at alpha, beta, gamma, delta. The mutation that is occurring here is literally 3 specific amino acids that are being expressed incorrectly, and that's changing the way this virus acts, which should be quite concerning in the sense that, okay, 3 amino acids suddenly turns this entire screen to a different area of focus, a different color. This B16172, which is the Delta variant, largely came about from the outbreak that occurred in India. So if that's the case, then the anticipation is you're going to continue to see some degree of mutation, and the mutation occurs based on is going to occur based on stress. So when you look at the technical variants that are happening right now, what do we understand about the Delta variant, which again, as you see on the right side, is this receptor binding domain or receptor domain effect. And what that essentially means is this spike protein has to bind to a receptor, ACE2 receptor, in the nasal and lung epithelia. And what this particular mutation allows is increased localized replication, especially in the nasal cavity. That's something that we can actually measure. So what we know happens when there's more virus that's replicating in a localized position, such as the nose and the lungs, is that if you cough or if you spray any sort of breath condensate, you're going to increase your transmission. And the data is pretty clear on that. And there's one other term that I'd encourage everyone to get comfortable with, and that's called the CT, or the cycle threshold, which essentially is the number of cycles. So, example, they put a little bit of fluid in your nose, they take a swab, they isolate that, and then they start to amplify with real-time PCR the number of cycles it takes to hit a fluorescent signal equivalency. So what that means is, if you don't have a lot of virus, you don't need a lot of cycles. Or if you don't have a lot of virus in your nose, you need a lot of cycles to reach that threshold. If you have a lot of virus in your nose, you don't need very many cycles. Think of it that way. It's a lot like titers. So in the patients who have Delta, the amount of cycled thresholds needed is very few. They are highly contagious. There are not values between 5 and 9, depending on the studies you're looking at. More importantly, people who are already vaccinated, if you measure their effect, these are people who are vaccinated and now they're sick with symptoms, their ability to affect other people is significantly limited. Often R naught is around 1 in the very few studies that are out there. But if you look at the cycle threshold data, it is pretty clear that you have a pretty good degree of protection. So what is unique about the Delta variant is receptor binding domain, the ability to pass the infection on, especially if you're unvaccinated, the inability to pass the infection on efficiently if you are vaccinated, and that's about what we understand at this stage. We also understand that the current vaccines we have available have a different degree of efficacy on the Delta variant. Unfortunately, we only have data on Pfizer. J&J, Moderna have not done any direct studies on Delta that have been published so far. Novavax and AstraZeneca have done some, but those are not available in the US at this time. Overall, the first kind of 2 studies that were published looked at, again, you got 2 doses and you were fully vaccinated. You had 88% effectiveness against symptomatic disease, 96% against hospitalization. However, Israeli data, which they had a larger percentage of people who were vaccinated for a longer period of time, they only had 39% effectiveness against that infection, at least late. And that was, again, this is all point infection, all point symptoms. So I think the question then became, what happens next? What is the next step? And this is really what happened next. This is, again, Israeli data where they looked at, this is going back to July, middle part of July. And you can see these are people over the age of 60 who had been vaccinated well over 6 months prior. And they saw the rate of infection was high. That's the left side on August 1st. They immediately started vaccinating with 1 more booster, just a single booster of the same old shot. And you start to see the case rates go down significantly. Hence, this single study is actually what triggered a lot of the discussion around whether we need to get a booster or not. So is Delta, a serious problem? We obviously know it's a serious problem. It's not as serious for people who are vaccinated, at least based on the molecular data that we understand. We also understand that the vaccinations we have currently do not clearly give us, 100% protection, which was never the expectation. but it does protect in other ways. So the question now becomes, do you boost or do you not boost, and when should you? We don't have, again, outside of that Israeli data, a lot of clear understanding on this. However, the basic issue is the same. We want to produce enough neutralizing antibody to provide protection from serious disease. If you look at the actual data from any of the vaccines that are currently available, estimated duration of chronic neutralizing antibody production is about 6 months. So you get about 6 months of legitimate protection. After 6 months, you start to see a decline. If you have immune system problems, immune system morbidity, if you are on any sort of immunomodulator, you have Crohn's disease, you have psoriasis, you're on TNF agents, if you're on anything like that, this is a different discussion. There might be a greater decline in that antibody response, and clearly age, especially the 7th, 8th decades of life or more, happen to lose that degree of immunity. We have the ability to test with appropriate, approved, FDA-approved testing these types of antibodies, these neutralizing antibodies, at least against the spike domain, with chemiluminescent assays. And if you look at the range, this is what's available at Quest and LabCorp and so forth, is between 0.4 and 250 units per ml of this specific type of semi-quant test. Is there a number that's clearly protective? There's a little bit, I'm talking like cases, small studies between 20 to 30 individuals in the healthcare setting that generally say if you're above 200, it seems to have the greatest level of protection. So this is something that people are starting to look at. You can go test yourself if you've been vaccinated and determine where your number is to determine if you need to go ahead and get another vaccine right away or not. Right now, if you're out many, many months or if you're at level of risk, I would say there's a minimum risk to revaccinating or getting a booster. But remember, this is not a typical booster. You're literally getting another dose of the primary vaccine. Another aspect of this is what happens if you've already had a native infection. So if you already had a native infection plus you got vaccinated, what does that mean? Should we be technically vaccinating those individuals? We don't have any clear data on that. I think there's a concern if you over-vaccinate and over-boost individuals. That has been conferred by many, many studies over the last 3 to 4 decades, that you can create auto-antibody responses that are ineffective. In other words, you're creating more degree of disease that is almost putting you into an autoimmune state. There are other tests available recently that measure T-cell immunity, which I would really caution against using. T-cell immunity, in brief terms, is CD8 toxicity. We really rarely use this in a test if you're looking at, for example, viral infections. We use this for CMV, effectiveness to clear CMV post-bone marrow transplant, things of that nature. So the overall position we're in right now is, is there going to be a mandate to boost? I think there's a lot of questions about that. The answer is certainly not right this second. We want everybody vaccinated, and we want to get a sense of what that does to disease burden. At the same time, I would expect booster requirements for all individuals after about 12 to 14 months based on the current data that we're seeing. So hopefully, this is where, things move forward. But I want to kind of, end here with a few large points, and that is this. We have to start looking at index cases very differently. We cannot look at these cases and say, okay, it's a positive COVID case. You are either antibody positive post-vaccination, 2 doses, you're either antibody positive post-infection, or you have no antibodies and you're unvaccinated, you have no antibodies and you are post-infection, or you have no antibodies and you're post-vaccination. These are the current options that can occur. And with that comes a degree of risk of disease. And based on this, this is where a lot of information and research is kind of currently going, and especially in the very young and in the kids that certainly we deal with. The age-dependent type 1 interferons, or interferon alpha and beta, are really conferring protection for the younger kids. So there might be a different approach for whatever category a patient is in based on age, for example. Immune competency can also play a role in this. So the only way to technically guarantee a high antibody effect for everyone is with boosting, right? That's the only option that will change this dynamic. However, where we stand right now, when you see cases, I recommend looking at these cases as you see on this chart. I would imagine as this goes forward, meaning this surge goes down, There'll be other small surges in the next year, but much smaller. As the US hits 80% antibody immunity, which has been seen only in a few small countries so far, we'll start to see this kind of transition where, on the left, the case transmission will occur when immunity fades, meaning patients are going to lose their immunity and a case will be transmitted, and they may not have a booster either. So that's where you'll start to see case transmission. However, case transmissions will largely result in mild disease because of the situations that we've already discussed. In addition, the case transmissions will result in fewer quarantine requirements, as we've already seen in the last CDC guidelines, where even if you got exposed to somebody and you're having minimum symptoms, they don't want you to get tested for 3 to 5 days. Why is that? Because of that cycle threshold I mentioned earlier. The virus doesn't replicate fast enough. Therefore, you got to wait 3 to 5 days to get a positive test. So these kinds of dynamics will change. We're finally at number 4. Cases will be uniquely different in the elderly, the immunocompromised, and those again on immunomodulators. And lastly, you have to keep these antibody immunity levels high in the population. And I think it's going to take, again, this kind of continuous booster approach for at least a period of time before we get to that final stage. And lastly, I mentioned this, I think, every time I've presented, and I think it's important. Baylor has deployed this graphic here on the right for outpatient management of COVID. I think we have to be very smart about what this disease is. Even if you are vaccinated, I think that's a different question. But if you are not vaccinated or you don't produce enough antibodies, this is not a disease that you go home and just eat some chicken soup and hope you get better, right? They have tried, and many have tried across the country, different regimens in the outpatient setting, utilizing things to avert your pulmonary shunts, your hypercoagulable states, the inflammatory states. And over time here in the next year, as these cycles go, push forward, we'll see that the outpatient management has to be defined. These cases will become less, but they are not less to the point where you could ignore them. There's very recently in Lancet, there was an excellent article looking at the long-term effects of a COVID infection. And these are not necessarily severe infections. And one of the most troubling post-mortem analyses in one of the largest studies that was done here, recently published, was looking at a phenomenon called pulmonary venular thrombosis. Pulmonary venular thrombosis. This means past the alveolar and capillary circuit, that circuit in our lungs that captures most of our blood clots. Past that point, we are seeing pulmonary venular thrombosis that shoots off clots into patients' brain, kidneys, intestines, resulting in a lot of these cryptogenic thrombi. And that's happening from this disease state. So how this becomes a management process in treating COVID outpatient is the ultimate challenge. We have several clinical trials in phase 2 and phase 3 on 2 antivirals that I've listed here. Those look promising, very similar to the Tamiflu model, if you will. So I hope as time goes on in the next year that we move towards this goal, matching things, because one slide says it all, and that's this. This is the CDC's COVID-Net, the largest compilation of data on COVID, and the numbers speak for themselves. If you're fully vaccinated, the rate of hospitalization has gone up very, very slightly in the last 8 months, and you can see what has happened to everyone else. So again, I'd say the main takeaway message is understand how these variants are moving along, understand that the booster will not only be 2 steps, meaning a booster at this stage may just be a replication of the first vaccine, or it may be a novel booster that's developed with a much better adjuvant. We'd like to see that. Secondly, it's about antibody production and setting your index cases much better. That will allow us to make better decisions for patients. And thirdly, outpatient management and monitoring and treating these patients in the outpatient setting is the next phase of this disease.